Dr. Gomathi has, although she's joining us virtually today, she has been visiting Sri Lanka very regularly and helping us with the management of a lot of adult and pediatric liver patients who need transplant. So Dr. Gomathi, over to you.
Thank you very much. That's very kind of you. And I would say, actually, I miss being there. I look forward to when all of this chaos all over the world is going to settle down and I can meet all of you in person. Today's topic is sounds very simple, but something which is very interesting. And actually, the interesting part is that as every country evolves and starts doing more and more transplant, this topic becomes even more relevant. Something which in the early days might sound like a very theoretical subject actually brings into force a lot of practical questions and dilemmas once a country starts doing their own transplants. And I think currently Sri Lanka is in that fantastic phase when the number of transplants are going up. There's more focus on patients being referred to transplant centers so that they have a chance at transplantation. And we were in the same stage, India, about 10 to 15 years ago, when the number of transplants were very far and few. And in fact, most gastroenterologists were used to one particular way of treating liver disease, which is essentially no definitive treatment. And they would all be symptomatic treatment, taking care of them, and eventually lose their patients. So this is a transition phase from when liver disease patients have no other choice but to just stay on and die to getting something like a definitive therapy, which is transplantation. So it's very important to understand during this transition as to which would be the ideal time to refer them out. So my talk is going to start off with, are you able to see my screen?
Yes, we can see it clearly.
Only thing, I'm not able to move my slides. Let me just stop sharing and reshare once again. So for the discussion for today, I mean, we will not focus on acute liver failure, because for acute liver failure, I think the one thing we need to keep in mind is to send the patient to a transplant center at the earliest. We will not at a non-transplant center discuss whether this patient fits criteria for transplant or not. Do we wait until then? Because it may be too late. By the time they fit criteria, if they get referred to a transplant center, it may be too late to optimize the patient and take them up for transplant. So in acute liver failure, just a statement is sent to a transplant center at the earliest. The entire discussion for today over the next 15 minutes would be on chronic liver disease. When do we take care of the patient at our level, which is at a non-transplant level, or send them to a transplant hospital? I understand the audience has a mixture of students also, so I would keep it a bit, very simple level just for understanding so that it is easy reference for referral. Now, what is it in chronic liver disease? The most important thing is understanding the natural course of the disease, not so much the etiology alone. I'm sure this entire list of indications for transplant, all of us have read right from our medical school to our, specialty training. But it is not really the indication or the etiology. It is to understand how each patient, the course of a particular patient and the disease in the patient. Of course, we've all read about the broad guidelines of CTP score and, more recently the MELD score. Well, the CTP, we know A, B, C, definite indication for transplant. Early B to A, maybe we can monitor. Late B, definitely transplant. But again, this is easy when you put numbers together. But when a patient walks into your office, this may not really always help. And even the MELD score, MELD score is probably what is revolutionized organ allocation over the last maybe 15, 20 years, since 2002 in the US. But again, just MELD has not helped, and MELD sodium is what is now more predictive of mortality as they wait on the list. What is important really? Not numbers, not scoring. How do we differentiate a patient has slipped from compensated cirrhosis into decompensated? That, I think, is the key. Understanding this aspect whatever the score is. That will help us in identifying which patient needs a transplant. Simple, of course, indicators: variceal bleeding, uncontrolled, not able to manage them with your multiple EVLs, ascites needing repeated paracentesis, encephalopathy, of course, carcinoma, which doesn't fall into the decompensation, but an indication for transplant. If any of this pops up, then you know, yes, definitely. But there are so many other situations which you'll be seeing in day to day, which come under what's called MELD exceptions when you have to list them in the US. But in general, what it means is these conditions are not identified by MELD, but definitely these are patients who will benefit from transplantation. For example, ascites with repeated tapping. MELD score is not going to reflect that. The GI bleed where the patient has may not be overt bleeding, but constantly dropping hemoglobin, portal hypertensive gastropathy, colopathy, constantly having a low hemoglobin needing transfusions. Encephalopathy, grades. I mean, it is not the one who's going to be in the hospital for it every time, but is having memory loss, not able to focus at work, sleep disturbances. Hyponatremia, we know, has already been included in the MELD sodium, but again, does not get points in the MELD score for listing. Hepatopulmonary syndrome, a cirrhotic patient who's been with you several years, follow up, you start noticing that they are becoming hypoxic. Very important. This is something which is missed out in patients, and I can give you an example of one of our own patients. A patient who presented with acute Wilson's, bilirubin close to about 20. She was 21 years at that point. By the time there was evaluation undergone for live donor transplant, her father was 49 years old. By the time they could get their finances together and the evaluation completed, she was diagnosed as Wilson's, then started on penicillamine. Over the next 1.5 months, her bilirubin started falling so nicely that she did not need a transplant at that point. So we essentially did not proceed with live donor, instead placed her on the wait list for a cadaveric transplant because she was medically stable, but we know she had a acute Wilson's presentation. So just to keep it as a safety net, we placed her on the deceased donor wait list. What happens over the next 3-4 years? She has no signs of decompensation, is very stable, normal liver function, good synthetic function. So she even comes off the deceased donor wait list. Subsequently, her follow-up also kind of slowed down. She was not very compliant. She was 22 when she first saw us. 8 years later, she got married, you know, her family priorities, so she stopped coming for evaluation. She comes to us in 2019, just prior to COVID. Her oxygen saturation was 82. Room air saturation. So there is an indication for transplant. She has developed hepatopulmonary syndrome at this point. Unfortunately, with COVID and stuff, she did not come for follow-up. She ended up with COVID infection, and it was quite a nightmare to pull her through that because she had COVID pneumonia. And subsequently, just after she got better from COVID, 6 weeks later, we persuaded the family the importance of transplant. She's had a transplant since. She's had a live donor transplant. She still needs oxygen support. She's about 6 weeks post-transplant, still needing only about 3 liters of oxygen from her 12 liters pre-transplant. So this is a condition where, you know, we need to keep watch of them. Cirrhosis, as much as we look for HCC, we need to look out for hepatopulmonary syndrome or portopulmonary hypertension, which may develop and which become indications for transplant, not necessarily reflected by your MELD score. Pruritus, of course, in patients with PBC, quality of life is such an important component. And so pruritus is something we need to take into account. But Chiari syndrome, acute presentation, is also considered as status 1 in the US. But when it comes to presentation in countries where there's not so much of a regularized deceased donor program, it's important for us to pick up. Other conditions, of course, quite rare, like amyloidosis or cystic fibrosis. All these are rare conditions, but these are more common that we see in India, and I'm sure in Sri Lanka also. Polycystic liver disease. Their liver function is not going to show up that they need a transplant, but they're so malnourished. They're so uncomfortable with their large cysts that they don't eat, and of course, they do have an indication for transplant. Primary hyperoxaluria, absolutely normal liver function. They will never get a liver transplant if we go by the regular criteria. But what is important is understanding the disease so that as the renal function deteriorates, if we can do a liver transplant preemptive, we may be able to save the kidneys, or if the patient has developed kidney failure, they need liver and kidney transplant. The common indication, of course, hepatocellular carcinoma, most of us see when we follow cirrhotic patients for a long time. Once again, I would like to say that a center which does not do transplants should not get into the specifics of whether this patient fits a criteria. Should I refer or not refer? I'm telling you this because the scope of transplant for HCC has been ever expanding, especially with live donor liver transplant being the predominant form of transplant in this part of the world. And also in the Western countries, when they want to expand criteria, they look at live donor transplant because it does not justify giving a deceased donor organ to a patient on the wait list with extended criteria. So currently, I don't know where we are going. Where are we drawing the line? But criteria keep expanding. The UCSF up to 7, as many tumors, no restriction on size of tumor. So bottom line is, HCC in a liver transplant patient, early, late, kindly refer to a transplant center. So the call is taken as to risk benefit or the acceptance of that particular patient and the center to offer transplant or not. Currently, actually, even macrovascular invasion is not considered an absolute contraindication. Patients do undergo SBRT, tear, downsizing of tumor, and go ahead and have transplantation. So there is nothing that it could be relative contraindication, but I don't think we should stop ourselves from referring just because an HCC is picked up on a CT scan. Now, long-term results, this is from Nature publication last year. So we've reached a point when we started talking about, even if it is way beyond criteria, which is the special group who will probably benefit from transplant? How do we give them a better survival? I'm going to merge the next two topics given to me, which is pre-transplant evaluation and optimization, because they go hand in hand. What we do in pre-transplant evaluation is essentially understanding the particular patient's disease, whether there is any reversibility component which can be addressed. And once we decide that there is no reversibility component or transplant is the only option, then we go ahead with risk assessment for the patient. So that is what we do when we call pre-transplant evaluation. When it comes to optimization, it's basically trying to modify the risk that's been assessed. For example, if a coronary artery disease is picked up, is it going to be a risk at the time of surgery or in the immediate post-op? Can we stent, get the patient better? If the patient has portopulmonary hypertension, am I going to treat that to get the hypertension better, to get him ready for transplant? So whatever is possible to prepare the patient so that you can get the best outcome in the given scenario. Again, the transplant evaluation, I'm sure each hospital has their own set of things, but these are the broad categories under which the patient is approached. Of course, I start with financial screening. This is a paper from the US, so it starts, but I think that's something which is important in every country. I think in Sri Lanka, you have a very good health system where the state takes care of all the medical needs, pretty much like the NHS. But the Indian scenario is not like that. Most patients have to pay for themselves. So that is an important criteria before we proceed with transplant. But having done all of that, we move on to the medical assessment, which is hepatology, confirming the diagnosis, optimizing the patient. Laboratory assessment, what we can optimize in terms of electrolytes, renal function. Serology is very important as hepatitis C. Currently, there are so many options to treat the patient beforehand. So depending on the current MELD score of the patient, whether there is HCC or not, the patient is given a choice of, not a choice, I would say, patient is given the opportunity to have Hep C treated prior to transplant. But if HCC is a factor or the MELD score is high, then you could proceed with transplantation and start the antivirals soon after transplant. Now, markers of other cause of liver disease, autoimmune, important to know. And again, ABO-RS blood typing, we have the blood bank officer consulting the patient, definitely pre-transplant, for two reasons. One is to make sure that there are no minor antigens which make the patient a high risk for positive cross-match, in which case we have to be doubly sure before we accept a cadaveric organ for the patient. that we have adequate blood. If it is a live donor transplant, we have enough time to plan and proceed. Second thing, of course, is for donation, so that, from the family members, so it helps with the transplant, the entire, blood bank's reserve. Kidney function monitoring is very important. Urine analysis and drug screen in patients, where you list them for to make sure that they're not under the influence of any of the substances. Cardiac evaluation, we'll talk more about a bit later. Hepatic imaging, essentially from the technical standpoint, a CT scan is a must, or an MR in cases where you cannot do a CT, to look at portal vein patency, but more importantly, HCC, and for technical reasons to look for any collaterals, large collaterals which need to be ligated at surgery, a very large spleen, splenic aneurysm, in which case you would like to do a splenectomy. And these are by and large the reasons why we would like to have a good imaging before proceeding. General assessment, tumor markers, malignancy screening based on the age and the etiology, surgical evaluation, anesthesia evaluation, essentially from the portopulmonary and from the HPS standpoint. These, although mentioned last, have a very important role. Psychiatry or psychology evaluation, social work, financial and nutritional support. We'll talk about each of these a bit later. And hepatitis treatment, we already spoke about. Now, when it comes to the cardiac evaluation, again, most of these, there are guidelines. But when we look at patients, and especially in Sri Lanka and in India, we see patients with diabetes and NASH. It's very, very prevalent. So can we really stick to just the criteria mentioned about who should have a stress test, who should have a coronary angiogram? Is it worth taking the risk in this population who have a metabolic syndrome which has gone on for years and led to an organ damage? Our criteria is pretty tight when it comes to cardiac evaluation. And this particular study evaluated the AHA, American Heart Association's 2012 recommendation on who need further screening. What they did was they took this criteria and applied it retrospectively to about 220 patients and analyzed as to which are the patients who really went on to have a cardiac problem either during surgery or afterwards, or based on the evaluation had a coronary artery disease. Based on that, out of these 7 risk factors, the recommendation is if a patient has more than 3 factors, then they would need definite cardiac further evaluation in terms of stress testing or a coronary angiogram. Well, our center, we're pretty much stringent with this. Our age criteria is 50. If a patient is more than 50 years of age, has diabetes, has NASH as the etiology for liver disease, and of course all the others or any of the others, they would have a coronary angiogram. They would have 2 types of testing. One is a functional testing in the form of a stress test, either a dobutamine or a stress thallium, and another would be a anatomical imaging, which would be a coronary angiogram. So based on the previous study, this is where the sensitivity and specificity of more than 3 risk factors is very good in predicting a CD of more than 70% stenosis, and hence this group will definitely need both a stress test and a coronary angiogram. Pulmonary evaluation, again, I've jumbled the order a bit. Usually we come across hepatopulmonary syndrome and pulmonary hypertension, portopulmonary hypertension as the important ones that need to be screened. Those will definitely be screened by all centers. What we really need to look for is look at the other things which can really add to the morbidity and mortality post-transplant, and that would be COPD, interstitial lung disease, hydrothorax, quite common in patients with liver disease. But what is important is to see whether there's bilateral, and if there is left effusion, we invariably screen for pulmonary tuberculosis in this patient, because hepatic hydrothorax is usually a right-sided phenomenon. So any left pleural effusion in our part of the world, TB is something we need to screen for. Hepatopulmonary syndrome, are we going to deny a patient transplant based on severity of HPS? We have so far very, very occasionally done that when the patient is very severe. Anybody over 50 is going to be high risk, but we've not denied transplant. This young girl I spoke about, the patient with Wilson's, whose room air saturation was 82, Her PaO2 was 57 when we evaluated her for a transplant. So it is going to be a high-risk patient. So we plan accordingly in terms of early tracheostomy, counseling the family for long-term ICU stay, need for home oxygen. We don't know for how many weeks or months post-transplant, but these are things we need to get ready. But it's not that we're going to deny transplant based on this. But portopulmonary hypertension is slightly different situation. Anybody with severe portopulmonary hypertension will not have a transplant because the chances of on-table mortality is also quite high with severe portopulmonary hypertension. So when it comes to POPH, if we find moderate POPH, they're going to go on treatment, reassess them, and then take them for transplant. Of course, a lot of times it's volume issue, and with good diuretic management, occasionally, very occasionally, we've even done ultrafiltration to remove excess fluid from the patient and then reassess the portopulmonary hypertension. But there are specific issues which I addressed upon earlier, which I'm going to come back to, is tuberculosis. We were very conservative in the early years in terms of when we take a patient for transplant if we diagnose tuberculosis. The recommendation is at least 2 months of ATT and then take them for transplant. But that is not the situation in every patient. Sometimes we have patients, most often liver patients, who don't tolerate the full ATT. As a result, you're going to give them a modified regimen. And in that case, the 2-month period technically will not hold good. And another reason is if the patient has a high MEL, you will have to weigh the risk versus benefit of waiting for 2 months as opposed to going ahead with treatment with the transplant and giving the ATT post-transplant. So this has been our strategy of late. If the patient is very stable, we don't mind waiting the 2-month period. But if the patient is not tolerating the ATT or has a high MEL, has a risk from the liver disease itself, we would go ahead with the transplant and then start the ATT once the liver graft settles. Of course, this is also to do with, there are so many, there are occasions when patients develop acute liver failure from ATT. Those are active TB patients for whom ATT has been started and develop ALF. And in that situation, we do go ahead with transplant because considering the importance of the ALF. So we kind of extrapolated that and we have been reasonably successful in going ahead with transplant and treating TB post-transplant. Nutritional issue, it's a whole big spectrum. I'll talk about it. Technical, complete portal vein thrombosis is still, I wouldn't call it a absolute contraindication. Most technical issues depend on the center which is doing it, the experience of the center, and the amount of risk the patient and the center wants to take with that particular patient. So there is nothing absolute contraindication in technical. It's more on a case-to-case basis. And HIV, which was once considered a contraindication, is no longer a contraindication based on the CD4 count. And HCV co-infection with HIV was a very poor prognostic marker early on. Currently, with the direct-acting antivirals, again, that is not a problem. Impact of psychosocial status is also very important. Again, most of these are considered something that we don't see in our part of the world, and it's more a Western phenomenon. But I'll just like to draw your attention on one particular, again, I'm going to quote a patient. This is a gentleman who has Wilson's, again, neuro-Wilson's. So a bit neurologically compromised from the neuro-Wilson's. Parents, he's about 36 years. Parents, elderly parents have been taking care of him for the last more than a decade now. Now the liver has started decompensating. So they've come for transplantation, right? The transplant is not for the neuro-Wilson's because that may not reverse, but for the liver failure that's developing now. So apart from his elderly parents, he does not have any other support system. This is quite a dilemma because this patient is not going to be able to take care of himself post-transplant. And the parents, they are really old. Maybe, we don't know their lifespan. So this does pose a problem as to what are we going to do. We did look for social support to see who's going to take care. Are we justified in transplanting this gentleman? It's still a dilemma. We're not able to come to a conclusion. So these are real issues that we need to address. And very important would be psychological support in a patient where we transplant them for acute liver failure. Very often when young patients who either had, let's say, a suicidal overdose and then have a acute liver failure, have a transplant, in the post-transplant period, it is a very difficult thing for them to come to terms, one, with the fact that, of course, whatever problem they were in, that they're alive. But the second thing is that they've had such a big surgery, they were in coma prior to transplant, not realizing so much has happened. So it needs a lot of psychological counseling post-transplant. Nutrition, very, very big factor in the outcome, very often neglected, but something which has probably a very big role than what is actually estimated to be. It actually, like we all know, in most of gastroenterology, nutrition is such an important aspect we talk about so often, and more so in transplant also. It is known to affect every aspect, be it ICU stay, not just long term, but even survival 5 years has been different in patients who were malnourished pre-transplant. Of course, in liver disease, there are multiple factors which contribute to malnutrition. And very importantly is what happens with the losing muscle mass. So we do have NASH at one end, patients who are obese, who end up with liver disease. And here they are sarcopenia. Only worsen in the post-transplant period if we do not address it with very aggressive interventions. This sarcopenia can continue in the post-transplant due to several problems. One, their own obesity is not going to let them move around quite well. Immune suppression, steroids that we add, all of this is going to contribute. So it is very important to aggressively address it by physical therapy, work on the steroids a little bit more closely in these patients, and addressing their nutrition. It is very difficult to assess nutrition in liver patients, mainly because the normal factors which are used for nutritional assessment are so out of whack in transplants. The body weight is a representation usually of the fluid in the body and not the nutritional status. Similarly, each of these that you look at is so difficult to estimate. As a result, we need to look at multiple ways of giving us information. A very good dietary department who can sit with the patient every time during the pre-transplant visit and go over all of these with them, look at their progression of nutritional status with the intervention that is advised. It cannot be a one-time phenomenon. And dietary interviews, and of course we use mid-arm circumference and tricep skin fold for assessments. A very good meal plan, again, a dynamic one, cannot be a pre-printed one for everybody. It has to assess the patient individually and give them a diet form, which has to be revisited to make sure interventions are done until they reach what they wanted. Tube feeding, very low threshold for this, pre-transplant and post-transplant. Broad guidelines for managing the different situations, optimizing the patient in terms of the primary liver disease itself and the complications. This is your gastroenterologist. I mean, you know this better than me. So these things, yes, have to be done, but attention to other finer details really go a long way. I'm going to just rest my case by talking to you about a patient whom we transplanted recently. He's currently still an inpatient. He's a 58-year-old gentleman diagnosed to have NASH. He was diagnosed in June 2021. Ascites, multiple paracentesis since then, one episode of encephalopathy. In fact, had COVID infection also and was hospitalized for it. Luckily, he came out of that. MELD of 24, high bilirubin, INR around 2.5, renal functions okay, hyponatremia. He continued to have frequent fever episodes, diabetic, very malnourished. So it was at this point that he was referred for transplantation to us. Our evaluation, I'm just going to run through most of what we discussed now. First, understanding the current condition, he did have irreversible liver disease. So we were going to proceed with transplantation. A cardiac stress, and because he was NASH, diabetic, and 58, he had a stress test and a coronary angiogram. Coronary angiogram showed mild CAD, but stress test was okay. So we were okay with that. Pulmonary PaO2 was 90%. Sorry, this is not PaO2. This is SpO2 in room air was 90. He had a large volume ascites, so that was compromising a bit. So we accepted that. He also had a CT chest, which did not show any chronic changes. Echocardiogram, no pulmonary artery hypertension. Chest showed bilateral pleural effusion, right more than the left, but still left was there. He also had frequent fever episodes, malnourished. So yes, that was something of a red flag for us. Ascitic fluid did not have SBP. So he had both ascitic and pleural fluid evaluation for TB, which was negative. Urine showed urinary infection. We screen the paranasal sinuses normally. We have been caught out with fungal infection, sinusitis occasionally. So that is something of a routine we do. CT scan, cirrhosis, portal vein patent, no HCC. Prostate had multiple tiny abscess, could not be drained. It was not large enough drain, but probably that was leading to the UTI and the frequent fever episodes. Very malnourished. Psychosocially, he had his family with him. The son was going to be a prospective liver donor. So with this background, our decision was to proceed with live donor because he could not wait for a cadaveric transplant given his high MELD and his overall condition. We started NG feeding for him, high protein, adequate calorie and low salt fluid restricted diet. Antibiotics were started for the urinary infection, had to be continued for the next few weeks because of the prostate abscess. Physiotherapy was started even pre-transplant, even though he was malnourished, especially respiratory therapy was given. Paracentesis was done as and when required, and he had a live donor liver transplant from his son. It took us 3 weeks to get him to transplantation. He is now 15 days post-op. He has a good graft function, very good liver from his son, who was 22 years, I think. But what is important, he's still in the hospital. He's barely starting to walk now. We're continuing his nutritional and physical rehabilitation. But I think the importance of this case study was just to tell you that, yes, multiple problems happen, but we cannot aim to fix everything before we go to transplant. At the same time, we try and address and get him to transplant because with such a poor liver graft, unless he has a functioning graft, nothing else can be sorted out for him. Thank you very much for the opportunity.